Between rivaroxaban and betrixaban, what do you think are the differences between these two agents? And I mean specifically, like, is there any difference within indication or half-life, or how do you think about the presence of these therapies in the practice right now?
Well, I think in general they're both approved for the
Yeah.
medically ill prophylaxis. Betrixaban, in terms of looking at its pharmacokinetics, differs quite a bit. It has a very long half-life, more than 24-hour half-life. Rivaroxaban has a half-life somewhere around 9 hours in a healthy volunteer, maybe longer, 13 to say 19 hours in patients who are elderly. If you look in terms of administration, rivaroxaban at the 10 milligram dose, as opposed to the 20 like we use for atrial fibrillation, does not require that you have to give it with food or a meal. Betrixaban, you actually give it with a meal, but it's actually not necessarily to increase absorption, it's to prevent higher absorption. So you're trying to actually prevent an increase in the Cmax and thus an area under the curve. Betrixaban has drug-drug interactions with P-glycoprotein inhibitors, whereas rivaroxaban, it's certainly limited to a combined P-glycoprotein inhibitor with a strong CYP3A4 inhibitor. So there's very few drugs, like ketoconazole is one of those, but we don't really use oral ketoconazole anymore. But there's certainly probably more P-glycoprotein inhibitors that would have an interaction with betrixaban that are used more in practice, like, for instance, carvedilol as an example.
Oh, yeah, that's really
So there's probably more drug interactions that would require a dosing adjustment. Also, if you look in terms of renal dose adjustment, there's more of a renal dose adjustment with the betrixaban than there is with rivaroxaban.
Yeah, that's interesting. And certainly we would say that, so both drugs are indicated. Betrixaban has a much longer half-life, with rivaroxaban's certainly shorter. And you sort of went through sort of the differences in interactions. How does the half-life affect how you think about using these in these patients that are medically ill?
Well, I think when betrixaban was first approved for extended prophylaxis, again, you started in the hospital, and I think one of the concerns of practitioners was how to manage such invasive procedures, as an example, if you're having a drug that has a half-life of longer than 24 hours, because we don't monitor or measure any anti-10A levels in these patients. So I think that was one of the reasons why, especially in someone that may have impaired renal function or something, where you would be more concerned about doing those procedures even on hospital day 2. So they're both administered as a single daily dose, whereas at least with rivaroxaban, I think there's a little bit more comfort from using it in the higher doses, even in hospitalized patients, and maybe either just holding the dose and doing the procedure and then reinstituting the dose. Similar to how we use subcutaneous unfractionated heparin in patients that are undergoing highly invasive procedures.
Yeah,
just kind of delay the dose.
Yeah, I delay the dose. I often think about rivaroxaban use in the hospital very much like how I think about enoxaparin, going in and out of procedures and holding a dose or two or delaying a dose after. So I often tell people it's safe to restart when you would restart one of those agents, because that's probably how you're going to be getting that effect. And in the clinical trial data, we saw some of that.